Okay, so welcome. Thank you everybody for joining us today for our talk from Dr. Anayansi Lombardero on CBT-I. We have been eagerly awaiting this presentation for a couple of months since insomnia seems to be one of the chief complaints, for lack of a better term, that our callers have, understandably. Dr. Lombardero is actually an assistant professor and clinical psychologist at the University of Nevada, Reno School of Medicine, where I am also employed. She is the curriculum director for years 1 and 2 for our medical students, and she has a specialization in CBT-I, also treating depression, anxiety, post-traumatic stress disorder, smoking cessation, and also weight management. She came to us from Alaska and has been all over the West doing her training and her postdoc. So we are very excited to have Dr. Lombardero with us today. And without further ado, I will let you go ahead and get started.
Good morning, everyone. It's really good to be here, and thank you for that introduction, Dr. Cotton. I especially appreciate you pronouncing my name correctly. I'm not used to that was quite a treat. And I just want to say how grateful I am for your time in terms of volunteering to help fellow physicians as they, of course, experience difficulties dealing with this the stress associated with this current pandemic. And so my talk today is going to be on cognitive behavioral therapy for insomnia. And my understanding is that because you're receiving phone calls from people complaining of difficulties with sleep, I made this presentation into something that you could use. So I tried to make it as practical as possible. So there isn't going to be a lot of research in terms of the efficacy and effectiveness of CBT-I. But if you're interested in learning more about the research supporting the use of CBT-I for chronic insomnia, I'm happy to talk about it. I do have a few slides at the end of this presentation. I don't want to keep you for any longer than you need to be here. But that information is available. I also want to say that I included my email address. So if you have any questions that you don't get to ask at the end of this presentation, I'm more than happy to communicate via email as well. So the agenda for today is to go over how we conceptualize insomnia from a behavioral perspective. I will go over the treatment components of CBT-I and their application, because I want to make sure that you're able to use, even if you're not doing CBT-I, that you're able to use some of the useful components from it in terms of providing your callers with advice in terms of what they can do to address their sleep problems. And I also included some information that was specific to insomnia, sleep problems during this home confinement due to the COVID-19 pandemic. This was from the task force of the European CBT-I Academy, and I've provided a link to the article so you can have access to it. I'm hoping that this presentation will be useful. If there are things that you would like to know more of, please let me know, and I'm happy to answer questions at the end. So before we get started, I want to go over the DSM-5 diagnostic criteria for insomnia. Because there's a misperception that because someone's having difficulty sleeping, they automatically qualify for a diagnosis of insomnia. Now, I know that you're not giving people diagnoses, but for your practice, it's just a helpful reminder of what insomnia is according to the DSM-5. So for a diagnosis of insomnia, the person has to have a predominant complaint of dissatisfaction with sleep. This can be sleep quantity or sleep quality, and it's typically associated with difficulty falling asleep, difficulty staying asleep, or many people also experience early morning awakenings. Many people have more than one, so you might ask people if they have difficulty falling asleep, staying asleep, or both. They might say both. It has to cause clinically significant distress or impairment, of course. This sleep difficulty has to occur at least 3 times per week, and it has to be present for at least 3 months. If it's not present for at least 3 months, then it would be acute insomnia or situational insomnia. And you can still give them a diagnosis of other specified insomnia disorder or unspecified insomnia disorder. I believe that it's been at least 3 months since the current self-isolation, social distancing guidelines started associated with the COVID-19 pandemic. So many of the people who are calling you may actually meet criteria for insomnia disorder. This sleep difficulty has to occur despite adequate opportunity for sleep. So if they are unable to sleep because of long work shifts or for other reasons, and then it's probably not insomnia. Can be better explained by another sleep disorder or the physiological effects of a substance or a coexisting mental or physical condition. It's also good to take into account differential diagnoses, which could include normal sleep variation. So some people may wish they were able to get 8 hours of sleep, but the reality is that they just don't need 8 hours of sleep, that they function fine with 5 hours of sleep. If they're not distressed by it, it's not insomnia. There's, of course, situational or acute insomnia, which can turn into chronic insomnia. We also want to consider whether the person actually has a circadian rhythm disorder or sleep-wake disorder, narcolepsy, parasomnias, such as sleepwalking nightmares, sleep terror, etc., or if it's a substance or medication-induced sleep disorder, insomnia type, obstructive sleep apnea, and for these, having access to a specialty sleep clinic is key. So let's talk about CBT-I and what it is. I am hoping to make sure that we're clear in terms of some common misconceptions. Some people think that cognitive behavioral therapy for insomnia is the same as sleep hygiene, and I just want to highlight that it's not. CBT-I is essentially a cognitive and behavioral therapy that's designed to help address cognitions that are interfering with one's ability to sleep, as well as behaviors that are incompatible with good sleep. As I said, there is plenty of evidence highlighting the efficacy and effectiveness of CBT-I for chronic insomnia. Sometimes these studies use sleep hygiene as a comparison group. Sleep hygiene works well if someone has bad sleep habits. It's not going to do much for someone who has a diagnosis of chronic insomnia. Another question that comes up in terms of insomnia, difficulty sleeping, is whether insomnia is a symptom or whether it's a disorder. And so we know that for people with depression and anxiety, there are often complaints about poor sleep, difficulty sleeping, difficulty falling asleep. So if the disturbed sleep is associated with a psychological or medical disorder, if it's due to substances or if it's due to stress, then it's a symptom. If however, there is distress or impairment that's actually associated with the disturbed sleep, then the diagnosis would be a primary diagnosis of insomnia disorder. So before we get into the details of the various components of CBT-I, I wanted to start talking about how we conceptualize insomnia from a behavioral perspective. And so I'll go over the 4P model posed by Spielman and colleagues. Sometimes, depending on where you get your literature from, you might hear about the 3P model of insomnia. Essentially, the 4Ps include predisposing factors, precipitating factors, perpetuating factors, and then the fourth model that you may, or the fourth factor that you may or may not see is what we call Pavlovian factors. Again, classical conditioning, which you probably know from your training. So in order for someone to develop insomnia, they have to be vulnerable or predisposed to sleep problems. This can be by virtue of having a highly sensitive or a malfunctioning biological sleep system, or a hyperactive arousal system that interferes with sleep. As you can see, these predisposing factors are not enough to move someone above the threshold for insomnia disorder. What happens is that if this person has or is exposed to a particular stressor that serves as a precipitating factor for acute insomnia, they will develop acute insomnia. So this could be work-related stressors associated with the COVID-19 pandemic. This could be a loss, this could be travel, it could be a number of things. And then for acute insomnia, as you can see, this is what's mostly driving the insomnia. For chronic insomnia, however, once those precipitating factors are no longer as predominant, what maintains the insomnia is what we call perpetuating factors. And these are simply behaviors that are meant to increase one's sleep quality or quantity. So essentially, we call it sleep effort. And it makes sense if someone is unable to get the amount of sleep or the quality of sleep that they want, that they would then engage in an effort to improve their sleep. The problem with this is that many of these efforts actually have a paradoxical effect in that the quality of that person's sleep actually diminishes. So examples of sleep effort can include spending excess time in bed in an effort to improve the opportunity for sleep to take place. Sleep effort can also include worry, thoughts about one's ability to fall asleep, etc. And lastly, Pavlovian factors have to do with classical conditioning, which we'll talk about soon. So here, classical conditioning, again, has to do with sleep effort. So once a person develops a stress reaction associated with their difficulty falling asleep, they may spend time in bed worrying or tossing and turning. They might spend time in bed that's not pleasant because they're actually concerned about how they're going to be able to function the next day if they're unable to fall asleep. So for people who don't have insomnia, typically we tend to see the bed in a positive light. So there's an association, the bed as a place in which we relax and sleep. If there's this tossing and turning and worry, then we have what we call conditioned hyperarousal. So now the bed is a place for stressed, the bed is a place in which we are worried. And so in CBT-I, we want to address undo. You can't really undo this condition hyperarousal, but we can again create another association with the bed as a place in which we relax and actually get good sleep. I also want to go over this two-process model of sleep regulation, which is also key in CBT-I. The first process here is the homeostatic sleep drive, which is essentially our hunger for sleep. So it's similar to our appetite for food. These are both internal processes. Our sleep drive is going to be very low first thing in the morning when we wake up, once we've had 6 or 7 or 8 hours of sleep. And it's going to gradually increase as the day progresses, so that by nighttime our sleep drive will be at a point at which we just have to sleep. And in CBT-I, we address factors that interfere with our sleep drive. Then there's also the circadian clock, which essentially tells us when to wake up, when to go to sleep, etc. So again, for sleep drive, adenosine is thought to play a role in it. We have an increase in the intensity of this desire for sleep, the longer that we're awake, and then this diminishes as we sleep. There are factors that weaken the sleep drive, so the goal here is to make sure that we are avoiding engaging in these behaviors that are going to weaken our need for sleep. Factors that weaken the sleep drive include spending excess time in bed. So if someone is unable to fall asleep right away, they might go to bed earlier than they typically would. And that's actually going to be detrimental in terms of their ability to fall asleep. Also, just like snacking before a meal is going to interfere with one's hunger for some of us, napping or dozing before bedtime is going to affect our sleep drive. Sleeping in, many people with insomnia will sleep in an effort to again maximize their sleep, but this will make it less likely that they will be able to fall asleep at night when they want to fall asleep. The circadian clock is our internal clock that essentially sends signals that tells us to stay alert throughout the day. The key point to remember here is that there are environmental cues that entrain the clock to this 24-hour cycle. These environmental cues include timing and amount of light exposure. So we want to make sure that we are getting exposure to light first thing in the morning, that we're waking up at a regular time and going to bed at a regular time, and that we are engaging in activities such as eating, exercise, again, on a consistent schedule, so that we can have a very healthy circadian clock. This slide here shows you, I like it because I'm a visual person, so this shows you visually how this homeostatic sleep drive works together with our circadian clock in regulating sleep. So if you see here, this is our sleep drive, and it's going to be lowest first thing in the morning when we wake up. And it will gradually increase until it's so high that we just need to fall asleep. Now, at the same time, our circadian clock is sending signals telling us to stay alert so that we don't fall asleep as our sleep drive increases. And these signals get stronger and stronger in an effort to keep us awake when we need to be awake. There's a time, and that time is typically between 9 and 10. There's variability depending on the person, at which our alerting signals start to decrease and our sleep drive is going to be at its highest. And this is the window of time during which ideally we're going to bed and we are falling asleep. So we want to make sure to maximize this, to make sure that we're falling asleep at that time when we start to feel sleepy. So in terms of putting it all together, in order for us to have good sleep, we have to make sure that we have a strong sleep drive. So avoiding napping, avoiding spending excess time in bed, avoiding dozing. We also want to make sure that we have a correct circadian placement. So one of the benefits of the current pandemic and working from home for some people, maybe not for healthcare workers, is that you can adapt your sleep schedule to your circadian tendencies. So there are people with a strong night tendency. These would be the night owls. If a night owl tried to go to bed earlier than their circadian clock would want them to, they would just naturally have difficulty with that. So if possible, we want to make sure that we shift our sleep schedule so that it's consistent with our natural tendency. And people generally have a good sense of whether they have a strong night tendency or a strong morning tendency. So they'll refer to themselves as night owls or as morning people. There are questionnaires that you can also administer to folks to determine their sleep tendency. Lastly, we want to make sure that there's low arousal. So for people who have a tendency to stress and toss and turn and worry in bed about the next day, we can advise that they engage in relaxation strategies, that they start to wind down about an hour, half an hour before they go to bed. So all of this together will result in good sleep. So how do we know when CBT-I is indicated? Typically, CBT-I is indicated if a person has suffered from chronic insomnia. So the insomnia has lasted for 3 months. However, someone can still benefit from some of these principles of CBT-I if they're experiencing acute insomnia. If you talk to the person and you find that they're engaging in behaviors that weaken their sleep drive, such as spending excess time in bed, sleeping in, trying to make up for their lack of sleep by taking naps or dozing, then they're probably good candidates for CBT-I, because CBT-I will target these behaviors. Again, if they're engaging in behaviors that are affecting their circadian rhythm, if they're not exposing themselves to light during the day, or they may be exposing themselves to bright light at night. If they have an irregular wake time, then they can benefit from CBT-I. And if they have the tendency, which a lot of us with graduate degrees or medical degrees have a tendency to worry, then this can also be addressed in terms of the cognitive component of CBT-I. They're watching their clock. If they feel sleepy, and many people with insomnia will say this, that they feel very sleepy before they go to bed, but then as soon as they go to bed, they find themselves wide awake. So this is an indication that conditioned arousal has taken place. Again, we have classical conditioning here, and that we can target this through stimulus control. So the components and targets of CBT-I are, of course, related to the behavioral conceptualization that I've just described. So in terms of behaviors, we want to make sure that the person we're treating is engaging in behaviors that increase the sleep drive. And I just mentioned what these are, right? Refraining from napping, refraining from spending excess time in bed, refraining from dozing. We want to make sure that they optimize the congruence between circadian clock and placement of sleep opportunity, as I just said. Make sure that they strengthen the signal of the circadian clock. Again, exposure to light, if it's not, if they can go outside and exercise in the morning, that would be ideal. If they don't have access to that because they're in an apartment, to make sure to open all the windows or turn on the lights as bright as possible. If they're in a work setting, make sure that they have bright lights during the day. And we also want to strengthen the bed as a cue for sleep. How do we do this? We ask that they refrain from engaging in activities other than sleep or sexual activity while they're in bed. And we want to reduce physiological arousal, which can be done via mindfulness strategies, which my understanding is that you had a talk on mindfulness, so that's great, or relaxation strategies, progressive muscle relaxation, and so on. We also want to address cognitions that interfere with healthy sleep. So for people with insomnia, it's not uncommon for them to think that if they don't get 7 or 8 hours of sleep, they'll have a terrible day the next day, or that if they don't fall asleep right away, they won't be able to fall asleep. So these are cognitions that can be targeted, and I know that you're familiar with CBT, so you'll use CBT strategies to address these sleep interfering cognitions. We want to make sure to reduce cognitive arousal, address dysfunctional beliefs about sleep. So some of the same cognitions, sort of categories of unhelpful cognitions are going to be the same. So we have the same as in other problems such as depression and anxiety. So you may have people with a tendency to show all or nothing thinking or black and white thinking in terms of sleep, catastrophizing, right? This would include the thought that if I don't get sleep, I'm going to have a terrible day tomorrow. It's going to be awful. You know how to target those, so I won't get into those. And then address any obstacles to adherence. And these obstacles are typically related to cognitions that the person is having associated with their sleep. One of the most important components of CBT-I is sleep restriction. And this has to do with restricting or limiting the time that they're spending in bed so that their sleep drive increases and so that they're able to achieve what we call consolidated sleep, which will improve the quality of their sleep. If not the quantity. Sleep restriction is not fun. And many people, of course, don't like this aspect of CBT-I. So if someone does not meet diagnostic criteria for insomnia, we may not have them go through CBT-I. If we're limiting the amount of time that they spend in bed, that time frame is going to be directly related to the amount of time that they are actually spent sleeping. So for someone with insomnia, you might hear that they get about 5 or 6 hours of sleep, but they're spending 8 or 9 hours in bed. So what you would do is you would tell them to spend only 5 hours in bed, and you don't want to do less than 5 hours. Even if they say that they only sleep 2 hours, people with insomnia tend to underestimate how much sleep they actually get. And what this means is that initially they will get less sleep. So we want to be mindful of that in terms of any safety concerns. Stimulus control is another component. And I've mentioned this to some degree, but the goal here is to strengthen the bed and the bedroom as a cue for sleep. So make sure that the bed is comfortable, that you're only using the bed and the bedroom for sleeping and sexual activity. Cognitive restructuring is another element of CBT-I. Some people might argue that it's not the most important element of CBT-I, but we do find that many people with insomnia do have maladaptive cognitions regarding sleep. There's also relaxation and sleep hygiene. Sleep hygiene, you're probably all familiar with. It has to do with addressing environmental issues, limiting caffeine consumption, limiting tobacco use, exercise, eating, etc. So here's an example of sleep restriction therapy and how it works. This is someone who is spending, this is their total sleep time. So this is someone who gets about 7 hours of sleep, which is actually not bad, but they are spending 9 to 10 hours in bed in an effort to obtain sleep. So one of the maladaptive cognitions around sleep is that one must get 8 or 9 hours of sleep in order to function. So here this person is spending 7 hours of sleep. So in terms of sleep restriction, we would ask them to go to bed at a time, let's say that they want to wake up at 7. So they would, rather than going to bed at 9 or 10, they would go to bed at midnight and wake up at 7. So initially this is going to result in decreased total sleep time, but over time you'll see that their sleep efficiency increases as they spend a similar amount of time in bed as they are spending asleep. Again, the goal here is to increase sleep drive and to improve their sleep efficiency. So here's how it works. This is not uncommon for someone who experiences insomnia. They're spending all of this time in bed, but this time is spent, some of it is spent asleep, and a lot of this time is also spent awake. And this results in a disruption of the normal sleep cycle. So they will report that their sleep quality is terrible because they're not getting consolidated sleep. So they're not going through the normal sleep stages and getting the N1, 2, 3 REM sleep and so on. So as you reduce their time in bed, their sleep quality improves in that they're spending more time actually sleeping and less time in a state of wakefulness. And then once this actually happens, so once their sleep efficiency increases, one can move on to expanding the time in bed. And this is typically done by 15 minutes, depending on their need for sleep and their sleep efficiency. And so it's normal. Another thing to highlight is that it's normal for us to wake up in the middle of the night once or twice. And typically we just fall back asleep. That the expectation is not that one will never wake up, but that those awakenings will not last as long as they do for someone with insomnia. This here is just an example of a sleep diary, and we use this to get an estimate of someone's sleep efficiency and to get an estimate of someone's total sleep time. So as I mentioned earlier, people with insomnia tend to be very bad at estimating the amount of time that they are actually sleeping. So this provides us with information in terms of sleep onset latency, so how long did it take them to fall asleep, how many awakenings they had, how long these awakenings lasted, and if there were any early morning awakenings. And if so, how many minutes before they actually wanted to wake up. So we use this to, again, calculate sleep efficiency and come up with a good sleep restriction strategy. The other component that's important in CBT-I is stimulus control. So here the goal is to promote conditioning of sleep as opposed to wakefulness or misery, which a lot of people with insomnia will report that's associated to their sleep environment. So we tell them, so these are strategies that you can have that you can refer to. Tell them to go to bed only when they're sleepy. So don't go to bed at 8 if you're not sleepy at 8 because you're wanting to maximize your chances of getting sleep. Don't do that. Just go to bed when you feel sleepy. We also tell them if you're unable to fall asleep, get out of bed and return only when you're sleepy. And this is really sleepy, not just tired, but actually sleepy. We tell them to avoid any sleep incompatible behaviors in the sleep environment. So this could be anything along the lines of looking at one's iPhone or reading or looking at a computer or tossing or turning. The only activities that are allowed are sleep and sex. Tell them to wake up at a regular time and to avoid daytime napping. Now, in terms of cognitive restructuring, I know that you had a talk on CBT already, but some of the common problematic beliefs about sleep that we hear often include, I won't be able to get back to sleep if I wake up, or I won't be able to function tomorrow if I don't get enough sleep. And so these beliefs are problematic because they can result in increased sleep effort, which has this paradoxical effect of exacerbating insomnia. So we address this through behavioral experiments consistent with the CBT-I model, right? So if someone's saying, I'm not going to engage in this activity today because I won't be able to do a good job because I didn't get enough sleep, we ask them to rate the strength in terms of their beliefs about this prediction, and then we have them engage in that activity, and oftentimes they see that they actually did fine. Coping cards are helpful for a lot of people too. Something along the lines of, I'll tell myself that even if I didn't get good sleep, I may still function well, that in the past I've functioned relatively well on 5 or 6 hours of sleep. Paradoxical intention has to do with telling oneself, don't fall asleep, which can be useful at changing problematic beliefs. Now, in terms of relaxation and sleep hygiene, I'm not going to recommend one strategy over another. Most relaxation procedures are equally effective. So whatever you feel comfortable recommending, or whatever the person prefers in terms of relaxation strategies, whether it's mindfulness, progressive muscle relaxation, belly breathing, nighttime yoga, any of those should help. For sleep hygiene, again, this is what most people think of when they think of behavioral treatments for insomnia. These are helpful, but alone will not cure their insomnia. We do want to recommend that people limit their caffeine intake. Ideally, they're not drinking any coffee past noon. Alcohol is interesting in that people might report that alcohol helps them sleep because it does have a sedating effect, but what happens is that their sleep quality, even though they're able to fall asleep more quickly, their sleep quality will actually diminish if they've consumed alcohol. And tobacco use, of course, we want to make sure to address that. Exercise, as we know, contributes to better sleep and deep sleep, but we want to recommend that they refrain from engaging in vigorous physical activity before bed, so 3 to 4 hours before bed. If they have any clocks in the bedroom that they have a tendency to look at over and over, we want to make sure to tell them to remove those, and that the bedroom should be a quiet place. It should be dark and ideally cool so that they can maximize their sleep. I did find this an article that I wanted you to have because it has some of what you're looking for, which is a list of practical recommendations from a task force of the European CBT-I Academy. And this is for dealing with sleep problems during home confinement due to this COVID-19 outbreak. I will highlight some of what I thought was particularly relevant for you and your work with healthcare staff here. So in terms of sleep, some of the practical recommendations include working on stress, and there are specific recommendations associated with stress that's related to work in the pandemic, which I will not go over because you probably have training in terms of that. But one thing I wanted to highlight is that there is evidence that social support can result in better sleep. So if they make sure that they're staying connected with people via phone, email, etc., that can actually result in better sleep quality. They also recommend, so some of the things that I've mentioned here, regular exercise, trying to get natural daylight during the day, or bright lights at work, definitely not in the bedroom, engaging in relaxing activities before bed, eating light meals at set times and not before desired sleep onset. So if someone's consuming a meal right before bed, then the process of digestion can interfere with their sleep quality. So we want to avoid that from happening. There are some things that are inconsistent with some of the recommendations for CBT-I, but that are important to note here. Because they pertain to safety. So if symptoms related to lack of sleep include dangerous work-related mistakes, taking a nap can actually be beneficial. And again, short naps may not interfere with one's sleep drive as much as longer naps, but even a short nap can help someone who's having difficulties related to lack of sleep. Another recommendation made by the authors is to avoid driving home after a long shift. Again, this is for safety reasons. And then in terms of recommendations specific to sleep medication, and the authors recommend to avoid use of sleep medication if possible, just because there is no evidence that medication is effective for the long-term treatment of insomnia, and there is also a risk of physiological and psychological dependency. However, they do say that medication can be helpful for acute insomnia. So they're not recommending that people completely refrain from taking medication, but they do suggest that trying CBT-I as the first option is good and consistent with current guidelines. If CBT-I is unavailable or unfeasible or just ineffective, then a short-term benzodiazepine or hypnotic benzodiazepine receptive agonist might be effective. Also, if they are experiencing comorbid depression or anxiety, a sedating antidepressant might be beneficial. And lastly, I wanted to provide you with resources for online CBT-I programs for those people who may not have access to a psychologist who specializes in CBT-I. Unfortunately, some of them are quite pricey, and I included, there are many out there, I included only those that are based on research. Sleepio is a very good one. That's self-guided. It's around $400, but it is available for free through some employers, so they might want to check with their employers to see if they have access to this for free. There's Shodai, Restore, and CBT-I Coach is a mobile app developed by researchers at the VA. They might benefit from having some guidance. So if you want to, if you're curious about it, you can actually download it on your phone. It's actually fun to play with, and you can become familiar with it and then guide your people, your callers in terms of how to use it. So for final thoughts, we do know that CBT-I is highly effective. There's enough research highlighting its efficacy and effectiveness, and many meta-analyses. Also, I've included some of these here if you want to read them. CBT-I is a first-line treatment for insomnia and should be recommended before sleep medications. You can certainly use principles of CBT-I or suggest further treatment to those people who tell you that they're engaging in these behaviors, which we know are maladaptive, or if you hear some of these cognitions that you know from this presentation that will just contribute to their insomnia disorder. There's also more information available to you from the Society of Behavioral Sleep Medicine and the American Academy of Sleep Medicine. Here are some references if you wanted to take a look at some of the literature here. And with that, I will maybe stop here and share and ask if there are any questions.
Thank you so much, Dr. Lombardero. I will turn this over to Ben, who will lead the Q&A. We have some people in the chat who have been asking questions. So Ben, take it over.
Yes. Okay. Thanks a lot for Dr. Lombardero to give us such a very informative lecture. And I see Cheryl raise your hand. Maybe you can unmute yourself and ask a question. Thanks.
Thank you. Yes, one of the early slides, it said adenosine had a role in sleep homeostasis, but you didn't say what that role was and what was the source of the adenosine.
Yeah, so that is not very well understood. So I didn't get into it. All I know really, and what I've read is that, you know, in terms of sleep and sleep processes, there are a lot of mysteries, and we believe that adenosine plays a role in terms of this sleep regulation. What that role is, it's not entirely understood.
Does it help it or hurt it?
It helps.
It helps it.
Yes, yeah, it's in terms of the regulation.
So it's adenosine present in general in the usual diet, nothing in particular?
You know, I can look more into that and send you information.
That'd be great.
Sure.
Thank you.
You're welcome.
All right, so next question is brought up by Karen. Karen asking that is CBT-I effective if someone's primary difficulty is having difficulty falling asleep, or is the primary usefulness for people whose difficulty are awakening? So basically, it's it's a sleep onset issues or maintenance issue. CBT-I, which one is more effective for which condition?
So it's effective for they can still meet diagnostic criteria for insomnia if they're having difficulty falling asleep. So it's going to be effective for those who report only difficulty falling asleep. A lot of people report difficulty with both, but if you are seeing that some of their behaviors, as you ask questions about what interferes with their ability to fall asleep, if you're finding that these behaviors in which they're engaging are contributing to the problem or are consistent with the behaviors I described that serve to weaken their sleep drive or their circadian clock, then CBT-I is indicated.
I see. So what do you mean that CBT-I is more targeting in sleep onset issues instead of maintenance issues? Okay.
Mm-hmm.
All right. Also, Karen's mentioned about one of the program is gone. There's another issue in another program. So how about Karen? Karen, can you unmute yourself and just explain to us a little bit, in detail? Are you there, Karen?
Yes, sorry.
All right, sure,
so,
thanks.
Well, last time I looked for shut-eye, it was gone, and instead Pear Pharmaceuticals had bought it or something and was starting a digital prescription program called Somrist. When I look in the App Store, Somrist Study is available, but Somrist isn't. But supposedly Somrist is something that like a physician could prescribe a digital CBT-I program, and then the physician could actually see a dashboard. And I just wonder if you knew anything about that.
I don't. I have a psychiatry resident who's currently looking into these online technologies because she will provide me with some of that information, which I'm happy to share with you. They change so quickly that it's hard to keep up with them. But I know that when I did look at least at the free app that was the CBT-I coach by the VA, that's still available and accessible for free. And then Sleepio, I also went through that internet program. I did not pay the $400, but it looks like it is available, and some of these are offering some free services through the COVID-19 pandemic. So I'm happy to send you an updated list of resources, of online resources, along with the slides.
Thank you.
Okay. All right. So here is kind of a related question. I think Dr. Conrad talking about what do you think about the prescription of CBT-I apps? So personally, I'm not familiar with that. I don't even know you can prescribe a CBT-I. Could you please expand a little bit so we can have more resources later on. Thanks.
Yeah, this is Mark Comrade. Actually, the whole idea of a prescription app is kind of a new concept to me. I'm not even sure I can quite get my mind around the idea of the concept that there's an app that a patient can only get with a doctor's order. I don't know whether that means insurance will pay for it I'm not quite sure what the implications are, but this is a revolutionary new idea of an app by prescription only. And I'm interested to know, what our expert even thinks about the idea that whether there should even be restrictions on apps for CBT-I that the public can buy, such that it has to be obtained by prescription only. That just seems like a very novel and somewhat suspect concept. I'd be interested in her thoughts about that.
It does. I know that there are apps that are specific for addressing substance use disorders that are only available through prescriptions, and in some ways, I can see why, in terms of addressing a substance use disorder, that may make sense, because the goal for those is for the physician or whoever is prescribing the app to have some level of oversight over them. I do believe for insomnia, and I like the idea of these apps and resources being available to anyone who needs them. If there is a requirement in terms of clinician guidance, then I can see why. If the app was developed in that sense, I can see why. What was that?
Sorry. So yeah. So next question is that I think Omar mentioned about some study had suggested some benefit of short naps for cardiac and mental health. So how should we reconsider with restricting napping for someone who has insomnia? I think that was related regarding your mention about the sleep restriction as a way of dealing with this insomnia issue. I think it's also related to Dr. Gleitman mentioned about he also had a question regarding the definition between what is a short nap and a long nap. I think these two questions kind of related. Could you please give us some insight regarding all these? Thanks.
Sure. So a short nap would be something along the lines of 20 minutes, 15, 20 minutes, so half an hour. A long nap would be 45 minutes to an hour or longer. And again, and I know that there's inconsistent information in terms of napping and the benefits of it. So for people who don't have insomnia disorder, and they enjoy naps or benefit from them, there's nothing wrong with napping during the CBT-I treatment. And so this doesn't mean that they should never engage in napping behavior again. But during the 4-week or 6-week course or 8-week course of CBT-I treatment, we do ask that they refrain from napping. Now, there's some flexibility around this for people who, for whatever reason, do need to take naps, and that flexibility entails allowing for shorter naps, and that those naps should not be close to their bedtime, because the closer that the naps are to their desired bedtime, the more they will interfere with their sleep drive.
I see. Thanks. So this is actually a follow-up comment. I think it's important. Bernadette mentioned about, previously, I think that was the question Karen asked about adenosine relationship with the sleep. And Bernadette is actually mentioned about there's a book, talked about that. That's what she recommended. Maybe Bernadette, are you there? Maybe you can unmute yourself and elaborate a little bit on this topic. Thanks.
Okay.
Appreciate it.
of course, I forgot the details because I read the book a few years ago. But it's accumulating during the day, one of the things that's happening. And light, if I recall correctly, it's also very important. And so we replenish the adenosine. And the problem is that when you go, like you fall asleep at 5 or 6 watching your 7 for an hour or two, then when you wake up, you eat, you go back to bed, it's much harder because it's been depleted. I just love this book. This book written 3 or 4 years ago, explaining this mechanism, what to do. You know, caffeine is in chocolate. As a Belgian, I had to stop my evening chocolate, but it's very well done. And it's also telling us, of course, how essential it is to protect from infection, from cancer. I mean, they have very interesting studies. So it's such an essential subject. So I highly recommend the book. I don't have percent in it. I'm not the one who wrote it, but that's where it's explained. Thanks.
What is the name of the book again?
The book is Why We Sleep.
Oh, yes.
By Matthew Walker. There it is.
Right, handy. Okay, good. All right. Thanks a lot for the comments. Yeah. So here, this is an interesting question. Carol, I'm sorry, I'm not sure I pronounced your name correctly. Mentioned about
it's Carol.
Carol. Okay.
That's right.
Yeah,
Hi.
I think you asked this question. I have this question too. You asking basically, reading. we all have some kind of OCD. We want to make sure the definition is right. The reading, does that mean read on paper, prints, or read on digital ones? So will that cause some problem? Well, I sometimes read on my Kindle, before sleep. I don't know if it caused well, I think personally, whatever I read, actually help me sleep. I fall asleep right away. So maybe you can elaborate on that a little bit, Dr. Lombardero, so to see if your insight about that. Thanks.
Yeah, sure. So if you don't have insomnia or difficulty falling asleep, and you enjoy reading, I would say go for it and read. For people with insomnia, reading is going to interfere with, if they're reading in bed, this is probably interfering with their ability to fall asleep. When we tell them in terms of the stimulus control component of the treatment, if we tell them to get out of bed when they can't sleep, they can actually read, and then we would recommend for them to read a book, because and print, because we do also want to make sure that we are working in terms of reducing their exposure to light. So a book is probably a better option. We do advise against technology use after a certain time before bed, and that's just to work on the circadian rhythm signals.
I see. So mostly so mainly your point is that when people already have insomnia issues, it's no good reading. Doesn't matter where they're reading it from, right? So if you read after the insomnia is resolved, is that right?
Yeah, so they shouldn't read in bed. They can still, if they're getting out of bed because they can't sleep, then reading is fine. Any activity that will entertain them is fine. If one doesn't have insomnia and reading helps to fall asleep, for some people, just meditation exercise will help them fall asleep. But for people with actual chronic insomnia, the problem is more complicated than that, and it typically involves all of these elements that we talked about.
I see. Yeah, in your previous lecture, you mentioned about it, just basically restrict the bed only for sleep, right?
Yeah. Mm-hmm.
Okay, sounds good. And here, Melissa asked another question: is there a typical length of time that it takes of sleep restriction before sleep efficiency improves? And so also to do a sleep restriction, is it better to restrict it by a strict early morning get up time?
Yeah, so good questions. In terms of sleep restriction, we the wake up time is set. So we do want them to pick a time. Let's say that they want to wake up at 6 in the morning. Seems reasonable to me. So if we're limiting their time in bed, they're going to go to bed at midnight. So it happens on that end. The wake up time is not negotiable. It's going to be, and then we do ask them to pick a time that they will be able to maintain consistently. And so you reduce the time at night, so they might have to, they would have to stay up later than normal. And it typically works fairly quickly. So I do see improvements in terms of sleep efficiency. The following week it may take yeah, so it's just a week or two, and then you adjust the time in bed depending on the sleep efficiency as well as their need for sleep. So if you start increasing time in bed unnecessarily once they're no longer sleepy, then it's no longer going to be beneficial. So we do assess, monitor sleep efficiency as well as their need for sleep, and this is essentially asking them, how sleepy are you during the day. If they're very sleepy during the day, then we want to make sure that we're adding time to their schedule. If they're not sleepy during the day, then their current sleep schedule is working well for them.
Yeah, but I think we at the very beginning we all possibly need to rule out any medical causes, right? So yeah. Okay, here there, Sandra, maybe you can unmute yourself. You talk about a small device which can possibly help. I'm not familiar with this device, so maybe you can elaborate a little bit. Called a doodle. Sandra, you there? Sandra, Dr. Sandra Swantek?
Yes, I am here. So
okay.
the I don't even know how to pronounce it. It's but I did spell it correctly. It is an interesting little device that I've actually been using myself to help me sleep. And it some of the material that I've read on it suggests that it is used in the military to help with sleep there. So this is a small little device about the size of a hockey puck. And you touch it, it turns on for either 8 to 20 minutes. And this little blue light increases in intensity or in its size of the little circle that it projects on the ceiling, and then contracts. And the user is, the user breathes in as the little dot expands, breathes out as the dot decreases, and focuses on the breath. I mean, it's a technique that we use all the time for anxiety. This is a technique that I've not seen used for sleep. And I wondered if our sleep expert had any knowledge of this or further thoughts on its use.
I'm not familiar with that particular device. One thing I will mention is that it can be helpful. Again, this sort of obsession with one's inability to fall asleep, which is understandable, leads to an inability to fall asleep. So sometimes just focusing on relaxation, anxiety reduction instead, and not necessarily on sleep can actually result in an ability to fall asleep. And sorry, I was reading the comments if I missed part of your question.
Well, so I think Dr. Lombardero. So basically, you know, as we're targeting to frontline physicians, so you know they're all medical personnel, and they're and also trained physicians. So a lot of them are already aware of their sleep hygiene requirement. If they follow or not, that's another issue. So, but they're already aware of that. I think. As you mentioned about try to reduce cognitive arousal, so and a cognitive restructuring is, important. I might be, our focus when during the call, and our listeners mentioned about there's some app, on the phone, because I think, possibly at the end of the call, if we can recommend them use some, some like apps on the phone they can utilize on their own time, that possibly can help them. That's why I mentioned about the prescription of the CBT-I or the things that, I don't know if you have any knowledge about these, phone apps. I think one of our, listeners asking about this as well. So, are you aware of any, credible, phone app that actually can, do some of the CBT-I in that sense? I know you mentioned a couple of resources, and, but is there anything available right now that we can recommend to our, caller? They can just simply download, on their phone, either free or paid, and then they can actually, get some help from that, in addition to these, 15 or 20 minutes call with us.
Yes, so CBT-I Coach is available. I don't know if you can see it. It's based on research. It's available. Anyone can download it. There's no prescription needed at all, and it was put on by a team of researchers at the VA healthcare system. So that's one that can be recommended. It's available without a prescription.
I see. Okay.
And a medical professional should be able to use it.
Okay, sounds good. So I think we answered all the questions. If anyone have additional one, we just had, we're already off the limit a little bit. If anyone, want to ask a final question, you can just unmute yourself, then we'll wrap up.
I had a question about melatonin. So many of the healthcare workers are not on regular shifts. How do you feel about using melatonin to help with that regulation?
Yeah, so what I read, and this is included in the article for dealing with sleep problems during home confinement, is that there isn't a strong evidence for over-the-counter medications in terms of sleep.
But people use melatonin for jet lag to help shift their sleep cycles. Wouldn't you think it might help with the regular work shifts as well?
Yes, it's possible. I can't say with certainty. So from a scientific standpoint, it's helpful for some people. We also know that not to highlight the placebo effect, but for some people, just taking anything can be helpful, and so I'm not not familiar enough with the research on melatonin specifically, other than what I've read about there not being sufficient evidence for over-the-counter medication. I know that when I was at the VA, there were prescriptions for melatonin and hydroxyzine and things like that. But again, the first line of treatment that's recommended by some of these sleep organizations is CBT-I.
So, but Dr. Lombardero, well, again, she's a psychiatrist. Psychologist. Psychologist. Specialized in CBT-I. So possibly, psychopharmacology might not be her, area expertise. So yeah. So, but I think that will be our last question. And thanks a lot. For Dr. Lombardero to spend time in the weekend and give us such a very informative lecture. So Alison, I leave it to you. Alison?
Oh wait, no, I'm back. I want to address one question from Davi. Okay, Smitha already did. All right. Yeah, Davi asked if since we are restricting our recommendations as far as medications go, should we also not recommend specific apps or over-the-counter products like lavender oil, things like that. So we're not recommending any supplements, but we are able to recommend apps and things like that. And I'm working today on organizing the resources page for our volunteers on the website so that you will be better able to find those resources that you can recommend. Also, if you check on the website in the recorded lectures section, that has been dormant for some time, but it is now quite active, and you'll be able to see all of the lectures that we've had so far. And I'll get this one uploaded today as well. And we'll look at getting slides and everything else that has been requested uploaded too. Dr. Lombardero, thank you so much for joining us today. This was really helpful, and I know several people did request specific slides that could be duplicated. Would we be able to get your slides, post them to our website just for our volunteer portal?
Yes.
That would be really helpful. Okay. I think we had a really great question and answer session. We finished 7 minutes early. If there are any further questions, you can email Ben or me or Smitha, and we can convey them to Dr. Lombardero. And I think that she will follow up with some of the things that we talked about, and we will get an email sent out as soon as we get all that information. And Smitha just posted the password for our volunteer portal through the website, so you can get in there and check it out. I'm constantly updating things. If you think of anything that needs to be on there, you can go ahead and send it to me. I will put my email address in the comments. And Smitha or Ben, do you have anything else?
Yep.
Okay.
Thanks for having me, everyone. And my email will be posted on the slides too, so you're welcome to email me directly too if you would like.
Thank you so much.
All right. Thanks a lot. Have a nice weekend, everyone.
This was a great talk.
Thanks.
All right.
Bye.
Bye.
Bye.